How does CSF analysis help tell ADEM apart from MS? Imagine trying to tell two similar-looking puzzles apart. Cerebrospinal fluid analysis is like examining tiny puzzle pieces that reveal clues about what's happening inside the brain and spinal cord. Both acute, disseminated encephalomyelitis and multiple sclerosis involve inflammation in the central nervous system, but their CSF profiles often differ in meaningful ways. In multiple sclerosis, one of the clearest signs is the presence of oligoclonal bands in the cerebrospinal fluid. These are specific immunoglobulins produced within the central nervous system itself, and they show up in over 80% of MS cases. When doctors analyze the CSF, they find these bands restricted to the fluid, not present in the blood, indicating localized immune activity. In contrast, ADEM patients usually have a much lower chance of showing these oligoclonal bands, around 20%. When they do appear in ADEM, they tend to be found both in the CSF and blood, which suggests a systemic immune response rather than one confined to the central nervous system. This difference is a key clue because MS involves ongoing immune activity within the nervous system, while ADEM often results from a systemic immune reaction triggered by infections or vaccines. Another important marker is the IgG index, which measures how much immunoglobulin G is being made in the CSF compared to the blood. In multiple sclerosis, this index is often elevated, reflecting increased production of IgG within the central nervous system. In ADEM, the IgG index is less frequently elevated, although it can be in some cases, especially if the disease is severe or prolonged. Both conditions can cause mild increases in white blood cells and protein levels in the CSF, but these findings are not specific and can overlap. Sometimes, in rare cases of severe ADEM with large demyelinating lesions, protein and cell counts can be quite high, but this is uncommon in MS. A particularly useful test involves myelin oligodendrocyte glycoprotein antibodies, or MOG antibodies. These are more often found in ADEM, especially in children, and are rarely seen in MS. The presence of MOG antibodies supports a diagnosis of ADEM or related disorders. High levels at the start usually point to a monophasic or one-time illness typical of ADEM. If these antibodies persist, it might suggest a recurrent form, but generally, their detection helps distinguish ADEM from MS. Finally, the clinical picture adds context. ADEM often causes altered consciousness or behavior, known as encephalopathy, which is uncommon in MS. When doctors combine CSF findings with MRI scans and the patient's symptoms, they get a clearer picture. In summary, analyzing cerebrospinal fluid helps tell ADEM apart from MS mainly by looking at the pattern of oligoclonal bands, the IgG index, and the presence of MOG antibodies. These markers reflected different immune responses. MS involves chronic CNS-specific immune activity, while ADEM is usually an acute, systemic immune reaction affecting the brain and spinal cord. Understanding these differences guides doctors to the right diagnosis and treatment. Always remember, if you or someone you know is experiencing neurological symptoms, consulting a healthcare professional is essential for personalized care.